Cast in 3, 2, 1, start.
Good afternoon, everyone, and welcome to the April session of our virtual Grand Rounds, Emerging Public Health Issues. I'm Dr. Kim Newell-Green, the moderator for today's session on Black Health in California, Moving Towards Equity. Today, I'm thrilled to be talking with Rhonda Smith, the Executive Director of the California Black Health Network. I think many, if not most of us, are aware that deep inequities exist in the health of Black people in California and across our country. But how deeply do we really understand the causes of these disparities? What I love about Ms. Smith and her organization's groundbreaking work is that they're engaging communities, elucidating the root causes of the disparities, dispelling commonly held misconceptions about Black health beliefs and behaviors, and working to take these lessons and learnings and develop a statewide strategic approach to improving Black health. As usual, we'll also hear from California State epidemiologist Erica Pan with updates on the front lines in California. Next slide, please. Just some housekeeping. Here are our speakers' disclosures. Next slide, please. Here's our agenda today. Next slide, please. And a reminder that our series is accredited for CME. You'll be sent a survey after the completion of the webinar where you can attest to your attendance. And when you complete that survey, we'll send out your certificates. Next slide, please. So let's go ahead and get started with Dr. Pan. Thanks so much for being here, Erica.
Sure. Good afternoon, everyone. Thanks so much for having me again. I'm going to do a little bit of a quick lightning updates on a few hot topics today, and then turn it over to our main speaker. Next slide. So we'll talk a little bit about respiratory virus trends as we sort of close out this last season, and certainly top of mind for us in public health right now is highly pathogenic avian flu. So I'll just give some quick highlights on that. Measles is also top of mind as a highly infectious vaccine preventable disease that we are starting to see more and more of globally, nationally, and here in California. And a couple other quick updates as well on an evolving increase in meningococcal disease, and really trying to honor the theme of today too, just a quick snapshot of HIV disparities in California and a product empowerment that I hope will be a good segue to our main speaker. Next slide. So you all have seen these sort of dashboards and slides from me over the course of many months over COVID. So thankfully, as you can see, both for COVID and flu, we are definitely sort of decreasing as far as hospital admissions, deaths, and test positivity, and many other respiratory viruses have been decreasing as well. So our main update on this as well is that after the end of April, this dashboard will no longer have information on hospital admissions because some of the background requirements on data for those are no longer going to be required nationally, but we will still maintain, at least in the short term, deaths and test positivity to continue to monitor. As many of you know, we've often seen sort of a summer surge of COVID, so this will be one way we can continue to monitor that as far as test positivity, because that is still reportable from the labs, and we'll continue to monitor that. And stay tuned for how we will be looking at respiratory surveillance for the next season. Next slide. And then just again to compare how different this past season is, the darkest blue line here as far as hospitalizations per capita, and how we thankfully have had a much lower hospitalization rates over this last season compared to those two big peaks are, of course, the first couple winters of the pandemic. Last year was milder, and thankfully much milder this past season. Next slide. So shifting to what we are preparing for and working on and keeping a close eye on is highly pathogenic avian flu. There was a CDC health alert that came out on April 5th. Next slide. And really want to just, as far as what's going on with this, wanted to give you a quick update that we've actually been seeing highly pathogenic bird flu in US wild birds since January of 2022. And there have been thousands of bird detections, multiple wild mammal detections, and many flock outbreaks, both commercial and backyard flocks. And probably over 80 million birds have been impacted. And that's just the ones that we know of and that were tested. But what has happened most recently is that there was detection of avian flu in dairy cows in Texas and multiple other states. And this is actually a new thing. Flu is actually not a known virus in cows historically. So this was first detected at the end of March. The primary location of the detected virus has been raw milk samples. And sick cows don't actually have a lot of symptoms the way humans or others do. It's very non-specific. They might have lower milk production, less appetite. It is also important to know, as far as milk supply, that pasteurization kills bird flu viruses. So another plug for pasteurizing milk. Next slide. And then what happened just also very, very recently is that there was the second human case of bird flu in the United States. And this was a dairy farm worker in Texas who was exposed to infected cows. The first case was in 2022, which may or may not have been actually even a contaminant, super mild symptoms. This patient actually, thankfully, also had very mild symptoms, conjunctivitis. The patient was positive for both respiratory and conjunctival specimens for avian flu H5N1. There's been no human-to-human transmission identified. There's been some concern that maybe there has been cow-to-cow transmission as far as a mammal-to-mammal, but our overall public health assessment is that the risk to humans remains low, and we want to continue to keep a close eye on this. As far as globally what's been happening, there have been about 13 H5N1 human cases due to this similar strain that's circulating now in North America, and that symptom severity has ranged from no symptoms to critical illness, including one death. And this is different than another bird flu that has caused more severe illness in Southeast Asia and other places. Next slide. We will be sending out another health alert on that soon as far as information to clinicians, but certainly if you have any dairy workers or others, we are closely monitoring anyone and working closely with agriculture on that, and more updates will continue to follow. And then shifting gears, also want to make sure that people are thinking about measles, especially right now. A lot of people are coming back from the spring breaks or going to international travel for spring break, or certainly summer travel and international travel. Next slide. And wanted to just share with you, we've already had 6 measles cases here in California, and over 120 cases in the US. There have been outbreaks in Chicago and other places. Again, this is a vaccine preventable disease, but as we've seen decreased vaccination globally, lots of outbreaks globally, we've seen unvaccinated travelers come back and then introduce measles into communities that are under vaccinated. So again, there have been multiple health alerts coming out from the CDC, from us at California Department of Public Health, and a couple quick reminders to you all as clinicians. Next slide. So we want to just make sure you're thinking about it, of course, first of all. And as you all likely know, in the beginning, it can be really mild symptoms that are hard to distinguish from an upper respiratory infection. But you do want to ask any febrile patient with the rash or any of the 3 Cs if they've had any international travel or even through international airports or interaction with international visitors. Many of you may remember we had an outbreak related to an amusement park in 2015. So those are other places where there's a lot of international visitors. And a reminder too that you want to isolate your patients immediately. If anyone is suspecting measles, get them into room immediately so you can avoid those waiting room exposures that you and your staff have to follow up on. And then call your local health department, who can walk you through both isolation using airborne precautions and N95 respirators, regardless of healthcare worker immunity, and help work with your front desk staff too to make sure you can triage people, try to get them right into a room and avoid the waiting room if possible if there's any suspicion about measles. There's a great clinician call with CDC and IDSA happening tomorrow as well, and there's a link in these slides for that if you want more information on measles. Next slide. And then I just had a couple other tidbits I wanted to highlight and share for you because this should be top of mind. If you are advised to test for measles or you're suspecting measles, it is really important to get an oropharyngeal swab and do urine testing for PCR. So antibody testing is frequently false positive, especially IgM testing, and is really not recommended. The standard and best testing to do right now is PCR. And then also just really want to remind you to not only check your own evidence of immunity, but your staff. I remember again in the 2015 outbreak, we had to exclude healthcare workers in sensitive occupations who didn't have evidence of immunity. And so you really want to make sure you and or your OC health teams have documentation of immunity of your staff so that you won't be excluding people because it can be up to, because of the long incubation period, it can be up to a couple weeks depending on when this is all noted. Next slide. And then also another thing that's come up is measles is starting to show up on some of these sort of panels. There's more and more rash panels. We're all more familiar with respiratory virus panels, but there are also some evolving rash panels where measles PCR might be included. And there have been a few cases in a recent MMWR that just came out about a few recent cases that were post-vaccination. So if an individual does have a mild rash after being vaccinated and was incidentally tested on one of these rash panels, were some of these situations. So just to let you know, and really again be thoughtful about what you're testing for, and you don't need to test for measles if someone has recently been vaccinated, unless they have some other epidemiologic exposure like international travel or known contact to a measles case. So it's a great write-up in this MMWR and some links here as well. Next slide. And then just as far as, again, as you gear up and make recommendations to your patients about before travel, making sure they are up to date on their MMR. Again, most of the cases that have been coming into the US are unvaccinated or under-vaccinated travelers. So you can actually give infants under 12 months an early dose between 6 to 11 months. You won't actually count it. They'll still need another dose between 12 to 15 months. And then again, their usual sort of kindergartenish dose, but you can, and we recommend doing that before international travel. And then if kids are over 12 months old, get that first dose immediately. And if you have enough time, you could even get that second dose 28 days after the first dose before that international travel. And similarly for teens and adults who don't have evidence of immunity. And here's some information again here about documentation of prior immunity. Next slide. And shifting gears now, there was also a CDC health alert at the end of last month about an increase in meningococcal disease. And again, most of you know, meningococcal disease typically causes bacteremia, meningitis, or both, often with some really severe multi-organ system failure. So as you also know, vaccines are available and recommended for teens and those at higher risk, including people with HIV. So we've seen, we had seen a decrease in most infectious diseases during the pandemic, and now we are seeing an increase again in invasive meningococcal disease, and it's largely more recently driven by a specific strain of serogroup Y. And nationally, we're seeing some variation here in the primary kind of demographic that's being impacted. So often you see a lot more pediatric diseases or young adults, but this has primarily been in 30 to 60-year-old adults. And we have seen a large proportion, almost 2/3 of the cases with this strain have been African-American individuals, and then 15% have been people with HIV who are not up to date on their vaccines. So we really want to remind clinicians, especially if you have patients who are HIV positive, to get them up to date on their boosters for meningococcal disease. And again, and the other unique thing about this currently circulating strain that's been increasing in incidence is many more are presenting with bacteremia and a few with septic arthritis, so not as typical of a clinical presentation. So again, refer you to this health advisory as well from the CDC, and wanted to make sure that is on your radars as well. Next slide. In California, we have been looking, and we currently have a similar case count compared to 2019, and we haven't seen any outbreaks or clusters or increases yet in California. Again, no outbreaks, but we have seen 58% of our cases are this serogroup Y. So this is consistent with some of the national data, but we have not seen the same demographic and risk factors, but we're again monitoring closely and wanting to increase awareness with all of you. So again, heightened suspicion for meningococcal disease, and particularly among, it's not as typical historically to be in older adults, but really thinking about making sure it's on your differential diagnosis as well. And again, making sure that people who are immunocompromised, including those with HIV, are up to date on their meningococcal vaccines. Next slide. And then finally, I wanted to conclude, again, hopefully is a good segue, just that HIV certainly affects our Black and African American communities more than any other racial or ethnic group. Next slide. And if we look at California data, we can certainly see that the rate of new HIV diagnoses are much higher, 4.4 times the rate of white men for men, and then for women, it's actually 5.7 times the rate for white women as far as new diagnosis. And then when you also look at our care cascade, unfortunately, there's also disparities in linkage to care, retention in care, reaching viral suppression. So this is a huge equity issue and problem with HIV here in California. Next slide. And wanting to really do a shout out to projects. And so we have some California public health funding for Project Empowerment, which is a demonstration product to really empower Black and Latino communities as a step to improve HIV prevention and access. You can see the goals here about reducing, preventing transmission, improving viral suppression, and most importantly, supporting innovative and culturally responsive programs that reduce those inequities and the stigma and the medical mistrust and barriers to HIV services. The goal of this project is to advance community health and wellness and recognize historical trauma that impacts health outcomes. So there have been core services. These are some of our key partners that have been funded on this slide. And this is improved uptake of HIV PrEP or pre-exposure prophylaxis, both for people who are HIV negative and linking people to HIV care for people with an HIV status neutral approach. So again, trying to really reduce stigma and barriers and really working with communities to come up with these programs that will work the best to help empower their communities to address these disparities. So lots of professional development services, podcasts, really supporting a new health center that is in a historically underserved Black community. So wanted to give a shout out, again, really honoring, looking forward to seeing Ms. Smith's presentation about Black health overall in California. Next slide. Some quick acknowledgements to individuals and branches that have helped contribute to these slides and our epidemiology. Next slide. And I think that is it, so I'll turn it over. Thank you very much.
Thanks so much, Erica, as always. And now we get to hear from Ms. Rhonda Smith. As already mentioned, Rhonda is the Executive Director of California Black Health Network. She not only has a bachelor's degree in civil engineering, but also an MBA, but also brings to her current role a wealth of experience in nonprofit leadership roles in which she's led many significant disparities initiatives in the BIPOC community. For example, she worked to transform the model of care of a network of FQHCs from a disease-focused treatment model to a prevention wellness model, providing whole person care approach, and also to identify evidence-based strategies to decrease the high mortality rate of African-American women diagnosed with breast cancer. So she is, has the background and the current experience to tell us about this work today, and so I will let her do so. Thanks.
So thank you, Dr. Newell-Green, for having me here today. I'm looking forward to having a discussion. I hear there are lots of really good questions that you all have submitted, so looking forward to having a dialogue around that. So today I'll talk to you about the work that we're doing to move towards health equity here in California. And if you go to the next slide, please. So I'll talk specifically about CBHN, or the California Black Health Network, for those of you who may not be completely familiar with who we are and what we do. I'll talk also about the state of Black health in California and highlight some key disparities, in addition to what Dr. Pan shared about HIV/AIDS. And I'll also talk about the work that we're doing in partnership with the California Healthcare Foundation to support the implementation of their work in the Listening to Black Californians research. And then talk more specifically about what we are doing as an organization to take action to promote and advance health equity for Black Californians. So next slide, please. So just a quick overview about the California Black Health Network, or CBHN for short. Next slide. So I'll begin by saying we are more than a 40-year-old organization. We were founded in 1978 and became a 501c3 in 1983. So 2023 marked the 40th anniversary of CBHN officially being a nonprofit organization. And so we, from the very beginning, focused on improving the health and well-being of Black Californians. So we have become the voice and trusted resource for Black health equity in California, and we are the only Black-led statewide organization that is dedicated to advancing health equity. I say for all Black Californians and African Americans and Black immigrants, it's included in that. And so there are Black-led statewide organizations that do work that are more gender specific or health related, but we cover, I say, the entire health equity spectrum from birth to death and parts in between. And so we do outreach, education, advocacy, and policy work, as well as programmatic work to advance health equity for Black Californians. And we do that through the lens of understanding the critical issues that lie at the intersection of racial justice, social justice, and environmental justice. Next slide, please. And so our vision, and definitely this came out of the work or what was being done and what was happening in response to the summer of 2020. And so our vision is to create a California where every African American and Black immigrant has the opportunity to live a long, healthy life that's free from violence, racism, and health inequities. And we do that work every day to realize that vision, to ensure that Black Californians, again, no matter who they love, how well educated they are, how much money they make, where they live, how they self-identify, or their housing status, or even where they're from, has access to high quality, equitable primary as well as behavioral health care, and definitely avoid unnecessarily succumbing to disease, especially chronic diseases that are preventable. Next slide. And so we do work really based on our health equity framework, which I mentioned a few minutes ago. That encompasses racial justice, environmental justice, and social justice. And we included environmental justice because we feel it's important to, and even a few years ago in response to what was happening in the summer of 2020, there was not a lot of focus, attention, or conversation around the environment and the impact of environmental factors and toxins, as well as climate change on Black and brown communities, and definitely not in California. And we felt it was imperative for us to have that as part of the work that we do in our health equity framework. And so our health equity framework really forms the foundation and the cornerstone for the work that we do around the Black health agenda. And I'll talk about that a little bit more in just a few minutes. So next slide, please. And so to activate our health equity framework, we launched the Campaign for Black Health Equity, which is our major fundraising initiative that supports our work to decrease health disparities and improve life expectancy of Black Californians. Our overarching goals for the Campaign for Black Health Equity are to drive key policy changes and advocacy initiatives. We know we're blessed to have funding from our grantors and large foundations in California, and we know that programs have a very finite period of time. And so programs can come and go, but we know that policy creates lasting change. And so we're focusing a lot of our efforts on policy initiatives that can help close the gap in health disparity and improve access to care. We also want to enhance our educational programs and offerings for, in some cases, healthcare professionals, but definitely patients and individuals across the state, and improve our brand visibility to become that respected thought leader across the state that will eventually be the trusted resource for the community and go-to organization for all things related to Black health equity here in California. So even though we've been around for more than 40 years, we haven't become a household name yet, but we're working towards that. And we are really expanding our reach and connections and presence across the state from Sacramento all the way down to San Diego. Next slide, please. And so the 6 core components of the Campaign for Black Health Equity is the Black Health Agenda, which I mentioned a few minutes ago. And that is really our statewide strategy and plan to close the gap in health disparities and advance health equity for Black Californians. And as Kim mentioned earlier, we involve the community very much in the work that we do, because we wouldn't exist if we didn't have the community engaged in our work and who we're doing this work for. And so we've engaged the communities from the very beginning as part of the process to develop the Black Health Agenda. We've done it in 3 counties so far, that's San Joaquin, Sacramento, and Alameda. And we have 7 more counties to go across California to complete that work. But the end product will be a statewide strategy and plan to close the gap in health disparities. We've created the Black Health Network, kind of being true to our name, which is a membership-based arm of Black Health, California Black Health Network. It's a very diverse group of individuals, healthcare professionals, community advocates, nonprofit organizations. We even have students that are part of our network. And Happy to report that we've grown significantly over the last couple of years. We started from ground zero about 2 years ago, and now we're fastly approaching about 600 members across the state. And, you know, bringing together folks across the state to really network, communicate, collaborate, and stay connected to work together more collectively to advance health equity, because we're at the end of the day, we're all striving for this towards the same goal. Doing that work collectively as a community and a statewide community will be critically important to advancing health equity for Black Californians. And through the network, we really hope to galvanize a Black health movement here in California through the people that are actually doing the work on the ground. The next thing that we've created that's relatively new to, that's relatively new to the organization is the Health Equity Forum. These are virtual venues and an event where we actually feature a thought leader or some subject matter expert in public health, health equity, and health disparities. We've had in the past Dr. Kizzmekia Corbett to talk about the COVID vaccine and the drug development process related to that, and also to dispel some of the myths and misinformation that was circulating around the community during that time. I think that was in May of 2021, and also provide our community an opportunity to ask questions directly of her about the vaccine. We also created the Health for Life initiative, which is our major initiative to improve health literacy of Black Californians. We aspire to really create a more empowered community of Black Californians that are really more proactive about their health and well-being, take charge and ownership of that, and really engage more in activities and actions that prevent chronic diseases from happening. And we also, as I mentioned earlier, wouldn't necessarily need to be a part of this work that we do as advocacy and policy. And we're really focusing on initiatives to get to the structural and systemic issues that create inequities and get to the root causes of these issues from the beginning. And health equity wouldn't exist without access to care. So we are a Covered California Navigator. We have a network of certified enrollment counselors across the state who enroll individuals, no matter who or where they're from, that are uninsured into healthcare coverage, and make sure that they stay insured. Next slide, please. And so I'll talk a little bit about what is the state of Black health in California. And so the life expectancy at birth of Black Californians is about 75 years, or about 5.5 years shorter than the state average. We know that COVID has probably added a couple of years to that, just like nationally here in the US. And then also we know that Black Californians experienced the state's highest death rate from COVID-19, or did from COVID-19 back in 2020 and 2021. Black Californians also have the highest rate of new prostate cancer, colorectal, lung cancer, and the highest death rate for breast, colorectal, lung, and prostate cancer. So unfortunately, when you look across the spectrum, you know, Black Californians are at the top of every list, similar to what is happening across the country. And so Black Californians also experience disparities when it comes to care, despite having a high rate of insurance, but we know that utilization rates don't necessarily match the 93%. And we'll talk about some of the reasons why as we get through the rest of the presentation. And so just like the rest of the US, when we look at maternal health, we know that Black mothers and Black birthing people experience the highest rate of maternal morbidity as well as mortality. So that's maternal morbidity. I always have a little bit of a difficult time saying that word, but yes. So more specifically, if we go to the next slide. We know that Black maternal health matters in terms of Black birthing mothers and birthing people are still 3 to 4 times more likely to die from pregnancy and birth-related causes, and unfortunately 2 times more likely to suffer from morbidity, as I mentioned. We also know that when Black infants, especially if you refer to the CNN report that came out about 3 or 4 years ago, there was evidence to demonstrate or prove that when Black infants are delivered by white providers, unfortunately, they're 3 times more likely to die during their first year of life, and 3 times more likely to die during childbirth. Unfortunately, Black mothers report that 10% of them report that they were treated unfairly during their hospital stay because of their race or ethnicity or assumptions about that. And then we know that 30% of Black women screen for positive anxiety during pregnancy, compared to about 10% of Caucasian women. So next slide, please. And as it relates to cancer outcomes, Black Californians have the highest rates of new prostate cancer, colorectal, and lung cancer cases. And again, as I mentioned earlier, the highest death rates for breast, colorectal, lung, and prostate. So we know that Black men are about 2 times more likely to die from prostate cancer. We know that even though Black women, there's more parity now when it comes to the diagnosis rate for breast cancer. They suffer a 33%, that's lung cancer, 33% higher rate than the state average. When we look at specifically breast cancer, we know that there's a higher mortality rate, even though, again, there's a lower incidence rate for Black women. But Black women are about 56% more likely to die from breast cancer here in California. Next slide. Also, when we look at diabetes or chronic diseases, unfortunately, Black Californians also are at the top of the list when it comes to the data for that. Black Californians are about twice as likely to be told that they have diabetes. They also have the highest prevalence of diabetes and also has the highest death rate from diabetes and diabetes-related illnesses. Next slide, please. And so that's kind of the state of Black Californians and what is happening with regards to their health and health outcomes. And so as I mentioned earlier, we are very fortunate to partner with the California Healthcare Foundation to support the implementation of some of the recommendations that have come out of their listening to Black Californians research. And so about 3 years ago, kind of in response to COVID, you can go to the next slide, the California Black Health Network really wanted to address some of the issues that arose out of what was happening in the summer of 2020, the George Floyd murder, COVID, and a host of other things. And so the California Healthcare Foundation really wanted to focus more of its efforts on work to really advance health equity for Black Californians. Next slide. And so the focus on Black Californians, I think it's pretty evident just based on some of the things that I talked about previously today. When we look at structural anti-Black racism, we know that that is part of what's encoded into our healthcare system as well as, our American society. Black Californians also experience the highest morbidity and mortality across most conditions, as I talked about just a few minutes ago. And California has the 5th largest Black population in the nation, and because of our geographic diversity, we can't necessarily ignore what is happening to Black Californians. And so we need to better understand that, especially us as an organization, so that we can use that to really guide our policy and advocacy and the work that we do from a programmatic standpoint as well. And so obviously, everybody knows COVID really heightened the attention on health disparities and health inequities, not just here in California, but across the country. Next slide, please. And so the Listening to Black Californians research was a statewide, there were a multitude of research methodologies that were used, but one was a statewide survey, excuse me, conducted by Aviderus, which is a Black-owned research and public polling company. And they achieved a population sample of a little over 3,000 adults in California who self-identify as Black or African American as part of the research and information gathering. The survey was preceded by about 100 in-depth interviews and 18 focus groups, all consisting of Black Californians across the state in urban areas, rural areas, all income levels, to really have more diversity and a voice of all of the collective representation for Black Californians. Next slide, please. And so I won't go through all the key findings, but just from the survey itself, more than 1 in 4 Black Californians avoid going to get healthcare or accessing healthcare because they feel like they will be treated unfairly or with disrespect. And so when we look more specifically at some of the breakdown of some of the respondents, we see A large percentage of women between the ages of 35 and 44 felt that way. Also, about 41% of Black Californians who identify as LGBTQ plus also feel that way. And then also about 35% of Medi-Cal enrollees do have the same sentiment. And so many Black Californians have adopted measures to protect themselves and prepare for their healthcare visit, and you know, sometimes altering their speech or dress or showing up in a certain way, maybe that's different than their authentic selves, just to make sure that they would be treated fairly and viewed differently. Next slide, please. And so as part of what came out of the research, Black Californians have a clear vision for what needs to be addressed when we talk about dismantling or addressing racism in healthcare. So definitely improving the patient-provider relationships are important to Black Californians. Almost all of them want a provider who listens to them. I think all of us do, regardless of who we are or what persuasion we are. About 93% of them want a provider to discuss their health goals and objectives and overall well-being. You know, getting more time with the provider, I think, would allow that to happen. But unfortunately, that's not always the case. And almost half of them want a Black or African-American doctor. We know that sometimes, you know, when we look at the research, when there is a healthcare provider who looks like us, the experience may be different and the outcomes may be different. Next slide, please. And so we know that the system needs to change. I think if we look at the healthcare system in the US, we know that we're operating within a system that is already broken. We know overall, you know, the US pays the highest in terms of per capita when it comes to healthcare. We know that at birth, we have the worst outcomes compared to most developed nations. And so we're operating in a system that is already broken. And then trying to do this work within that system makes it even more challenging. But at least 84% of Black Californians really desire more community-based education on how to navigate the healthcare system and be able to advocate for quality care for themselves as well as their families. Next slide, please. And so I'll talk a little bit about what are we doing to take action to promote health equity here in California. So next slide. So most of you are probably familiar with this definition, but health equity is the attainment of the highest level of health for all people. And then next slide. And more specifically, if we go to the next slide, it's the state in which everybody has a fair and just opportunity. I think fair and just is an important thing to reference. Also, it requires, I would say, more efforts to focus on dismantling those injustices and basically eliminating preventable health disparities. Those are mostly related to chronic diseases. And then valuing everyone equally, regardless of who they are, what their situation is, where they live or where they're from, so that we can eliminate health disparities and health inequities in healthcare. Next slide. And so I love this slide because, you know, for some folks, the reality, they have, you know, barriers, but also things that are not stacked up in their favor. And so if we think about moving across the spectrum and we look at equality, that means everybody gets the same thing. But everybody's situation and circumstances is very different from the next person. And so if we think about equity, it really is giving people what they need and tailoring that solution, whether it's healthcare or other, to what that individual really needs. But there still may be barriers that we're up against even in that situation. And so if we remove all the barriers, we can see a different level of engagement, a different mindset, attitude, and behavior when we have freedom to be who we are, receive healthcare that we deserve, and so forth. So next slide. And so now I often say that health really happens outside of the four walls of any healthcare center, clinic, hospital. And I love now that there's data that proves that. And so when we look at social determinants of health, there are basically four categories here. There's health behaviors, there's clinical care, there's, you know, external factors like the societal and economic factors related to income and wealth, and then there's the physical or built environment that also plays a role in that. And if you go to the next slide, we can see more specifically that the majority of things that make up or contribute to social determinants of health relate to external factors outside of those four walls. And if you click one more time, and even one more time, you'll see that about 80% of the social determinants of health that are related to external factors contribute to health outcomes. About 20% of that is related to actual clinical care. So really, when we look at patients, we have to look at the whole person and what their life is like, definitely outside of those four walls, because we know by the time a person shows up in an exam room or a hospital, it's really symptomatic of everything else that may be happening in their life and in their world. Next slide. And so looking at how we view health equity, it's moving from just documenting, capturing, quantifying health outcomes and health disparities, and really focusing on what we can do sort of upstream to prevent poor outcomes from happening in the first place. So focusing more on prevention and early detection, access to quality, equitable healthcare, giving people the care that they need based on who they are, their circumstances outside of those four walls of a healthcare center, and focus more on saving lives. We know that the majority of health conditions relate to chronic diseases, and the majority of those are preventable when we think about nutrition or access to nutrition and healthy foods, and lifestyle management, as well as physical activity. And so those are things that generally we have control of and can definitely focus on more to prevent diseases from happening in the first place. So next slide, please. And so going back to what I said earlier about us really being fortunate to have a partnership with the California Healthcare Foundation, we are a partner in implementing some of the recommendations that came out of the Listening to Black Californians research. And so I'll just run through quickly the recommendations, and I'll focus on the one area where we are partnering with them. So there's the increase in representation. This is related more so to workforce development. Also expanding community-based education and helping individuals understand how to better navigate the healthcare system and advocate for quality care. Also establish accountability for quality care, and then developing more holistic approaches to healthcare. Maybe having more of an integrative approach, looking at alternative or complementary and alternative medicine practices in addition to the Western way of practicing medicine. And so the area of focus for us is related to community-based education to help our community understand really how to make the healthcare system work better for them. And so next slide, please. So what has evolved from that recommendation and helping sort of answer the question, how to make the healthcare system work better for Black Californians, is the How Do I campaign. And that really is intended to help answer any question anyone may have about how to make that healthcare system work better for them. And so if someone has a bad experience with their healthcare provider, knowing that they can file a complaint, and how do they do that? Same thing with their healthcare plan. There's a way to actually file a complaint, or how do I get a second opinion if I don't think that this is the right healthcare partner for me? So answering a lot of those basic questions is part of the work that we'll do and the resources that we actually have available that live on our website currently. Next slide. And so in the How Do I campaign, we are expanding our community-based education efforts, again, under our Health for Life initiative, as I mentioned earlier. That is our major initiative to improve health literacy. So it makes sense for us to have that partnership with the California Healthcare Foundation to move forward and implement solutions to improve health literacy and that are more community-based education. And so if you click next. So again, really working to create a more empowered community of Black Californians, meaning that at the end of this, what we aspire to do and achieve is really helping the community understand what their patient rights are, helping them understand how to navigate through the healthcare system, how to communicate with their healthcare provider, no matter who or what type of provider they're dealing with, how to advocate for themselves and their loved ones, and how to participate really in the decision-making for their care and health management, and knowing that they should be at the center of that and be more of a partner in that process with their healthcare provider. And then ultimately, we hope that people really take ownership and believe that they have the power to prevent and manage their health condition, especially if they're related to chronic diseases. Next slide. And, I like to say that we're really working to ignite a Black health movement here in California. So between the work that we'll be doing for the How Do I campaign, the work that we'll be doing through our policy and advocacy work, and the work that we'll be doing with and through our Black Health Network, we can mobilize our community across the state to really become part of and ignite that Black health movement here in California. Next slide. So I mentioned the network. Again, this is something that we're really proud of. We've grown from ground zero to right now, at least as of the publication of this slide, 546 members. We are getting closer to 600. More than half of those are nonprofit organizations. We have healthcare organizations and individuals. We even have corporate members and some government entities that are part of our membership network and expands across the state. Again, from San Joaquin County to Alameda County down to San Diego, and also to the Inland Empire. Next, and could you click again? And just some areas of focus and things that have happened sort of organically through the membership network are peer networking groups. And so we have a peer networking group that focuses on healthy aging and seniors, also behavioral and mental health. We're focusing on more health access and advocacy, as well as Black maternal health and infant mortality. And so there are a lot of people in our network that are doing similar work in their respective communities. And so they actually do come together to collaborate, to share learnings and best practices so that they can all be more effective and impactful in the work that they do locally, as well as across the state together. Next slide. And then one of the last things I want to mention is we had a success last year on the policy front. We worked with the California Legislative Black Caucus, and Dr. Akilah Weber specifically was a champion for our Black Health Equity Advocacy Week resolution, which is a statewide resolution that declares the first week of May as Black Health Equity Advocacy Week here in California. I believe we are the first and only state right now. Actually, no, Washington State just did a similar thing a few months ago, but we have now a statewide focus to really uplift and elevate the need to focus on closing the gap in health disparities in the Black communities across California. This year, it is actually May 6th through 10th, and we will be launching a campaign in the next couple of weeks. So we'll be sharing a social media toolkit, and we want to garner more statewide engagement. Our core message for this year's campaign is we've got the power. So we really want our community to feel empowered to be engaged in changing outcomes and for their community, and also participating in influencing policy that can address some of these issues and greater access to healthcare and quality healthcare. We've started a health equity advocacy training program. We're on our second cohort now. We will be taking them to Sacramento that week of May 6th to have our own lobby days and meet with their state representatives. And then eventually we'll host a Black Health Equity Roundtable, most likely in LA before the year is over. Next slide. And then just a quick review of our legislative priorities. We're really focusing on getting to the root causes of health inequities and looking at what we can do to address racism in medicine. So we are part of a coalition that is looking at medical algorithms and what we can do to mitigate the racial bias that is embedded into medical algorithms. We're looking at implicit bias in healthcare, similar to SB 464. Also focusing on social determinants of health. We are a co-sponsor of Dr. Akilah Weber's Social Determinants of Health bill that we hope will get across the finish line, and Governor Newsom will sign it into law the second time around. So she's reintroduced it for this legislative session. So fingers crossed for that. And then this is more of my hope and dream for medicine, is that we move more towards personalized or precision medicine in primary care, like we have in cancer, and really looking at treating the individual and the whole person focus more on that individual and preventing diseases from happening. So we're part of the All of Us program. That is an NIH initiative, a national initiative, whose aspirations are really focused on moving more towards precision medicine and healthcare. Next slide, please. And then I'll just end with a quote from Martin Luther King, that all forms of inequity and justice, in healthcare is the most shocking and inhumane. So no matter who we are, where we're from, or any of those factors, we should all get access to quality, affordable, equitable healthcare. So our type of insurance should not dictate that, but the fact that we need to have quality care based on our individual needs is what's most important. And so with that, I'll say thank you. And if there's any questions, happy to respond to those.
Incredible. Thank you so much for that presentation. It's always hard to distill such incredible expertise in a massive body of work into a short period of time. And we do have lots of questions today, so I'm going to launch right in. One question is that we've heard a lot of evidence of disparities. We've heard sort of the bad news. Having had experience over the decades in this, can you point to any improvements or successes in the last couple of decades in Black health?
So I'll say that some of the improvements do relate to policies that have been passed here in California. And I say of all places to be in the country, I think California is the best place to be when it comes to accessing healthcare. So yes, there have been more Black Californians that have been enrolled in healthcare coverage, in large part thanks to the Affordable Care Act. So that is progress. So accessibility is there. Utilization might not be where we want it to be, but we're also, as part of the work that we're doing, helping, as we enroll folks in healthcare coverage, helping them navigate through that and understand now that what they have access to, especially if they were formerly uninsured. And again, going back to the policy and legislation, there have been, great legislation passed here in California, like the California Cancer Care Equity Act, which we were a co-sponsor of, along with the City of Hope and a few others, that now focuses on the Medi-Cal population. For those who have a more serious or advanced cancer diagnosis, they can now get access to treatment at a cancer center of excellence here in California. But what falls short is the implementation of those policies. So we're trying to do our part to make sure that our community and all communities that are part of the Medi-Cal system is aware of this, and that they know that they should have a conversation with their healthcare provider should they receive a cancer diagnosis. So if we look at the numbers haven't necessarily gotten better overall. We still know that there's a huge gap in life expectancy. COVID did not help that at all. Even though we've made progress with maternal health outcomes, there's still a gap and disparities there, and we're still. So in some ways, yes, in other ways, no, not so much. So.
Yeah, so much work to do.
Yeah.
One of the things that I noticed in a lot of the questions from our viewers were this eagerness to figure out how can we as providers work with you. So I hear you building health literacy on the side of the community. And so, for example, folks were asking, what are one or two things I can do to address this at the hospital level as a physician leader, or within county health departments? Or how can we help as medical educators? You alluded to that in some of the bills, or in pediatric settings. So in general, just an eagerness to help. And so are there steps that we in our daily lives can do other than advocate for all these important issues alongside you?
Yeah, so glad you asked that question. So we do view health literacy being on both sides of the patient-provider relationship. Our strength lies in community education, and hopefully, eventually, we will do more provider-related education, because I think it's important to understand the patient population that you're dealing with to be able to provide more culturally competent care. Be like on a day-to-day basis. Oops, sorry, often when I'm on, hold on. Sometimes it has a mind of its own, sorry about that. Yeah, so I can appreciate and understand what the life of a healthcare provider is like on a day-to-day basis and how taxing and stressful that is. But I think, one basic thing that can happen is just to take time to listen. In the time that you do have with a patient, to really listen and listen with an open mind and not necessarily with whatever preconceived notions that may have existed or we may believe, but really, listen to that individual and what is really happening in that individual's life that may be causing these issues or health issues to happen. And just, I think, treating everyone with respect, no matter, again, how much money they make, no matter where they're from, no matter what language they speak, just focusing on being more, providing more humane and human focused and patient-centered care.
Yeah. One question that a viewer had was, what about the health of other ethnic groups, be it Hispanics or Asians, indigenous populations within California? How do you think about your work and its potential to impact other racial groups?
Yeah, so I say if we're able to solve the problem and move the needle as it relates to health disparities for the Black community, then I think it definitely will help other communities. And we work in concert with other health equity focused organizations and their leaders like CPEN or Latino Coalition for a Healthy California. We're all in this together. I think at the macro level, our issues pretty much are very similar. But when you get to the micro level, because of cultural differences and other nuances, how it's impacting our community and how we address those issues may be different. And even within the Black community, we felt it was important to distinguish African Americans versus Black immigrants. And even in that category, there's immigrants from Africa, from the Caribbean and Latin America. And again, at the surface or the macro level, similar, but when you look at things at the micro level, even within the Black population, things are different when we look at immigrant populations, especially.
Yeah. You mentioned sort of the concordance of a patient and a provider, and we have a question about, is there data? Clearly, it sounds like from your research, many, not all, folks want to have someone who's a provider who gets them from the point of view of their race or ethnicity. Is there much data, or do you know the data well, on outcomes related to the concordance between patients and providers?
Yes, so we know, yes, there is research that shows that there are better outcomes. I mean, look at doula situation. We know that when Black birthing mothers have a doula that is a partner in their birthing journey, there are better outcomes. We know that when there's a provider who is more who looks more like us, there are better outcomes and higher level of patient satisfaction in most cases, and patient experience as well. So I think having lived experience is one way that you can easily connect with and relate to a patient if you're a provider. And so I think it's easier to get what that patient might be dealing with, more so than someone who doesn't share that same lived experience. And what it's like to walk in that patient's shoes every day, for sure. Yeah.
Right. Well, we don't have much time, but I want to ask a final question, and I always save the difficult one for the last, unfortunately, so watch for it. I guess the question is, how hopeful are you? And my original question was that we'll achieve equity in a reasonable time frame, for example, my or your lifetime. And now I'm going to say, how hopeful are you that we'll achieve liberation for Black folks in California in a reasonable
in our lifetime, right? Yeah, right. Well, I'd like to hope that, through the work that we're doing and how we're really engaging the community in this work, and especially around the advocacy and policy work that we're doing, that, we are able to come together to address the issues that are impacting our community. I say, it has to be not only about us, but for us and by us. And so, being engaged and participating in the process is at least what I hope can happen. And I think as a result of that, we'll start to see change happening. And so maybe some of the folks that are participating in our health equity advocacy training program might themselves decide to run for office to represent their community and really be the voice of the community when it comes to making policy decisions or creating policy that can really have an impact on Black health and Black health outcomes. So.
Great. Well, I want to thank you, Rhonda, for your incredible work and all of your team in this arena and for coming and sharing it with us today. I also really want to thank all of the participants who, upon signing up, asked really deep and engaging questions and have done so during this. And so we wouldn't be here without you. I also want to thank Erica, as always. Just a reminder that you'll receive that survey today where you can attest your attendance, and so we can send out your CME certificates. And our next session will be on Tuesday, May 14th, where we'll discuss the expansion of child behavioral health services in California. Super exciting, innovative programs that are launched. And then we have some great events coming up. You can see on the slide here today. On April 29th, CMA will be hosting an accredited webinar on artificial intelligence in healthcare. It's free, and we hope many of you will be able to attend. Additionally, CMA will be hosting the Health IT Summit, Health Equity Leadership Summit, and the Medical Group Advocacy Symposium. And there's lots of information at cmadocs.org/events. Have a wonderful day, and thank you all for being here.
Thank you. Bye-bye.